Thank you, everyone. Appreciate you coming to our session. We're talking about building the multi-D team, and this will really be sort of an overview and set the stage for the remainder of the session. These are my disclosures. So our objectives here are to understand the guidelines, and so I'll briefly go over the AUA-ASTRO guidelines for advanced prostate cancer, and then talk about why the urologist should be involved in the care of these patients, and particularly in building the team that we'll describe. And then lastly, we'll build a framework for the multi-D care of advanced prostate cancer patients based on the AUA-SUO guidelines. So here's the timeline that we're very familiar with. So most men who are being screened, checking PSAs, and if eventually diagnosed with prostate cancer, usually are coming under the umbrella of the urologist at some point. Even if they decide on radiation therapy, they need to see us for the elevated PSA, for the MRI, biopsy. Unfortunately, anywhere from 20 to 40% of men will recur even with intermediate risk disease, and many of those will move on to androgen deprivation therapy. And then the focus of this talk will be really about that point forward, the patients who develop resistance, who develop metastasis, and the different levels of therapies that are involved. And just, if you look at this slide from 30 years ago, this would be a much barer slide, but as we know, in the lead up to diagnosis, we're using MRI. Much more, we're using fusion for biopsy. There are plenty of genomic tests that are out there to risk stratify patients, and a lot of that is to, number one, avoid biopsy when possible, but then also identify earlier those who could be followed with active surveillance or need to progress on to treatment. We certainly know about all the different treatments, radiation-based versus surgical. And then we'll talk in detail about all the therapies in more advanced disease, but certainly in chemotherapy, immunotherapy, radiomics, and novel hormonal therapy are baked into the various stages that patients will progress through. And I hope that we emphasize throughout my talk, but certainly throughout the day, that there are plenty of clinical trials and really impactful research that's going on to reduce comorbidity, to improve therapies, targeted therapies, and ultimately improve survival. And really the urologist should be a part of all of that. So here are the states of advanced prostate cancer: biochemical recurrence, metastatic hormone sensitive, non-metastatic CRPC, which is probably a vanishingly shrinking state, and then metastatic CRPC. So just to go through a bit of the guidelines, for biochemical recurrence, for these patients, we should talk to them about their risk of developing metastatic disease, follow their PSAs. We can basically offer them observation versus clinical trial, but we should not routinely initiate ADT in these patients. In the newer guidelines, we should incorporate PSMA PET where available for these patients. In metastatic hormone-sensitive prostate cancer, we're more and more using doublet and triplet therapy in these patients. We should certainly offer ADT in combination with docetaxel and either abiraterone acetate with prednisone or darolutamide, and this is based on recent trials that have come out in the last several years, certainly Enzamet, PEACE-1, and Arison's, combining the novel hormonal therapies with ADT and docetaxel in the appropriate patient. In non-metastatic CRPC, we have a list of therapies that are available. We should certainly keep following these patients with serial PSAs every 3 to 6 months and looking at the doubling time, and this will be emphasized later on, but most of the clinical trials set a PSA doubling time of 9 or 10 months as sort of a cutoff for risk of metastasis and progression. And in these patients, several phase 3 trials and subsequent follow-up trials have shown that apalutamide, darolutamide, enzalutamide should be offered to these patients. And then should not offer systemic chemotherapy or immunotherapy outside of a clinical trial. And then for MCRPC, we have a plethora of treatments that are available. Again, we should be following these patients, ideally with PSMA PET, but certainly with CT bone scan at intervals of at least once or twice a year. They should continue with ADT with novel hormonal therapy, but for those who are progressing, we have several lines of therapy for the minimally symptomatic, non-rapid progressive Sipuleucel T. There is platinum-based chemotherapy. There's PARP inhibitors, which if you were in the breakfast this morning, you know, for patients with BRCA1, 2, or certain other mutations. For patients who have progressed in prior docetaxel, we have cabazitaxel as a second line. And then more recently, we know that lutetium therapy in patients with progressive MCRPC who have previously received docetaxel and ARPI can get lutetium-based therapy if they have a positive PSMA PET scan. So let's pivot to what the urologist's role in the multi-D clinic would be. The goals of a multidisciplinary clinic are really to provide comprehensive care to patients with input from experts from multiple disciplines and really create a one-stop shop. This can help simplify the treatment choice for patients. I mean, we have full rooms like this debating all the nuances of all the therapies. But when it comes to talking to the patients, we need to really present this information in a way that's digestible and actionable. We really want to give high-quality care with collaboration between urologists, medical oncologists, radiation oncologists, nuclear medicine, our physician extenders, patient navigators, and using the patient and family sort of as the nexus of all of that. You want to provide consistency. Many of our patients are being referred in. They've gotten all kinds of disparate information, and you really want to give consistency in messaging to patients. It's a great way to encourage and participate in clinical trials. And really, again, the goal is to improve survival and give patient satisfaction with the entire process. As I stated from the outset, the urologist is really involved with these patients from the beginning. You know, we've performed the biopsy. We may or may not have performed surgery, but even after radiation, we're following them, checking PSAs. And then some of the post-treatment complications. Some of these patients have urethral stricture. They have upper tract blockage. They have ED. They have hormone deficiency. So we're seeing a lot of these patients. We understand the natural progression. We've seen these patients throughout, and we understand each step of the different treatments they're getting, but also the adverse events that they may be experiencing. And again, patients have said they want continuity of care. It's sometimes a little disappointing for patients to get dropped by the urologist, even if we're not actively doing things. We're sort of a warehouse of information for them. And as I said, we can manage some of the complications of therapy that can happen that we create or happen in radiation therapy or any of the other treatments. And this has been shown in multiple states. Here is data from the hepatocellular world, non-small cell lung cancer, head and neck. So this is really the paradigm for treatment for complex cancers in multiple states. And really the guidelines, particularly NCCN guidelines, encourage a multidisciplinary approach when taking care of these patients. And you'll hear from Dr. Gamella later, but again, it may improve survival when you're using a combined group approach versus an individual or disparate approach. They started a weekly multi-D prostate cancer clinic in 1996, and in 2010 they published on their experience with a collaboration between urology, radiation, and medical oncology, genetics, and path. And what they showed, if you look at the side here, the blue line is the SEER data of survival in T3 and T4 localized disease. And the yellow line is what they experienced with their group in Philadelphia, and you can see improved survival. And so there is a benefit that we can give to patients when they're seeing experts in the same room or at least at a similar setting. So where do you get patients? You can certainly get internal referral if you're in an academic center, getting referrals from your colleagues. But even in group practices, if there are patients where your partners have performed a prostatectomy or seeing them after radiation, and you have established this clinic, you can get them in to see you. Certainly you can do manual chart review, but more and more using electronic medical record. AI can interrogate charts and identify patients. And so there's ways of getting either software or using AI to follow patients, look at their PSA trends, look at patients who are starting ADT, and then also for patients that may be eligible for certain therapies if they meet the criteria or meet criteria for clinical trials, identifying and then having you or your physician extender that can ping you to seek out these patients. So the urologist has expertise, and we should be sort of the conductor of the orchestra, so to speak. Certainly you want to know the guidelines and know all the different therapies, even if you specifically aren't giving them. As we mentioned in the breakfast meetings, we may not necessarily be giving PARP inhibitors, but we need to know what they are and how they are used. We can act as a resource for our partners, and particularly our physician extenders. APPs play a tremendous role in our clinic at Vanderbilt and some of the other clinics around the country. But they're the ones who can provide expertise based on the guidelines, can monitor therapy as they're going along, refer back to us if they're having progression or any changes in imaging, and really provide communication, particularly if you're at a different site. Another partner is specialty pharmacy, and they are really helpful. They, number one, can help identify patients and provide the expertise of the different therapies that are available. They are the ones who identify if there are drug-drug interactions, and they help with our patients who are on SSRIs, if they're on anticoagulation and we need to tinker with their medication. And they're also great in finding ways to reduce cost. So we have patients, most of our patients at Vanderbilt aren't paying any out-of-pocket or very little because they can meet with foundations, they can meet with industry partners, they can speak with insurance companies. And so lowering costs is a tremendous asset to reduce financial toxicity in these otherwise very expensive medications. So what can urologists provide? I mean, we certainly are familiar with the injectable and oral agents. With the second-line oral therapies, we do prescribe within our clinic. CYP-T we handle through our clinic as well. Many of the groups are giving PARPs and docetaxel within their practices, particularly if they have in-house a medical oncologist within the large groups. And surgical castration, I don't want to leave this in our history bin. This is actually the most affordable, durable, and quickest onset ADT that you can do. And certainly if you do a capsule sparing, they can still have something to show when they're in the gym. So we need to not forget that. So what are the models for a successful multidisciplinary clinic? And here I'm referring actually to some work that Kelly Stratton, who is here, and Mike Cookson. But these are the different components. And really there's two models. You can have the multi-D clinic where everybody is there, the urologist, the radiation oncologist, the navigator, the clinical trials coordinator, your geneticist, all at one place. And so they can sort of do the rounds, meet with everybody, and then you have a tumor board at that time, and then involve the patient with what we think is the best option, what are their options, and then allow them to decide. And then certainly you can have the model where they see the urologist first, and then we can have them meet with the various team members, either the same day or different days, but then again reconvene to have a tumor board. I do want to point out that we want to make sure that we have palliative care involved. And it doesn't necessarily have to be for end of life, but we can, they're comfortable in talking with patients of how aggressive do you want to be and all these different therapies. Here are some of the adverse events that you could experience. How can we get you through that and still maintain as much quality of life? And then when it does come to end of life, and many of these patients do progress, we want our hospice colleagues involved because we don't want to be beating up patients without any benefit. And there are multiple studies that have shown that patients who have entered hospice can actually live longer with better quality of life with de-escalation of therapy. So we don't want to forget our partners in that area. So I've mentioned that we do this at Vanderbilt, but is this solely the purview of a large academic center? And certainly not. Many of the LUCPA groups are some of the drivers of this. If you look at a lot of the papers, you'll see some of the lead authors are from large group practices. We in Nashville, our group, Urology Associates, has a multi-D clinic, and they mirror some of the things that we do. So obviously, these are ways that our community partners can participate. So just to summarize, patients with advanced prostate cancer have a myriad of options, and that is both a blessing and a curse sometimes just because of how confusing the conversation can be. And so using a multidisciplinary clinic can help make these discussions more straightforward and give them the best opportunity for survival, the best management, the availability of clinical trials. Obviously, you want to be familiar with all of the clinical guidelines because that really will drive the treatment decision making. And again, I'll reiterate again, don't forget our clinical trials. So thank you very much.